since I'm in the habit of moving while talking, so I hope people don't mind if I stand here. And I would start by thanking General Farhan and his team. Itne log hain, I think I'm fairly well audible. And General Sohail Aziz is also here. And I tell you that AFIC is my parent department. Nobody, even the current and the ex-team, knows it better than I do, because I've been associated with it since I was a young girl of 12. I used to go there with my father, so thank you so much. I feel very happy to be amongst you. And where is Brigadier Asif, who was very kind in arranging my accommodation. After that, I come to the talk. You have seen hi-fi presentations. There's nothing, very simple, down to earth, because I believe in basics. And you know, when we talk about, you have heard fancy treatments, and you must understand the pathophysiology and the principle of treatment and prognosis. And especially these days, we are talking about preserved heart failure with preserved ejection fraction. You have heard that incidence is rising. Maybe we can go to next slide. And according to WHO, in next decade or so, 75% of any medical or cardiac unit's bed will be occupied by patients with congestive heart failure. So it's such a huge problem and imposes a tremendous burden on society, both in terms of financial and manpower, and also the family gets disturbed. And so there is an increasing urgent need not only to prevent cardiac failure, but also to slow its progression. And what is progression? It reflects the underlying process of left ventricular remodeling, which results in decrease in ejection fraction, functioning of cardiac function, increased risk of lethal arrhythmias, and sudden cardiac death. Now the aim should be to prevent progression of asymptomatic left ventricular dysfunction to symptomatic heart failure. And so there is need to individualize the therapy, matching treatment to the patient's present history and maybe even genotype. So is an excellent tool to detect disease, its progression and prognosis. And you can also use it as a guide to select appropriate therapy in response to treatment. Now it's easy. How can you do that? With the use of your 2D and M mode, we can take ejection fraction, and based on that, heart failure was divided into heart failure with reduced ejection fraction and preserved ejection fraction and the minimal ejection fraction. That was okay. Now the difficulty was, or little complex, is your diastolic dysfunction. And this diastolic function, you have to understand the function first. This diastolic function is determined by rate of myocardial relaxation, left atrial pressure, left ventricular pressure and compliance, and loading conditions of the heart. Now, I will not go into that. This is the basic principle. You all know E and A in transmitral flow. Now, this is the most important slide. I won't waste time here. I will come straight to this one. Now, this one is very important. This actually 5 or 6 slides, and I've squeezed them into one just to save time and also for better understanding. As a matter of fact, we had it when I was working with Dr. Jamil Tajik at Mayo Clinic, Rochester. Now I've put the patterns there, and then symptoms, LSIs, left ventricular and diastolic pressure, and the pulmonary vein tracing there. As you can all see, the normal, your E is twice the size of A, no symptoms, normal left atrial size, normal left ventricular and diastolic pressure. Look at the stage 1, which is called delayed or impaired relaxation. One word of caution. When I see echo reports, a man of 75 or 80, they write grade 1 diastolic dysfunction, and believe me, the educated lot gets so disturbed. Madam, iska kya function? You should not write that. That is the normal aging phenomenon. And number 2, you cannot say grade 1 diastolic dysfunction unless you measure the deceleration time of the descending limb. And at this stage, symptoms are minimal. Patient is short of breath on exertion and chest pain, and your LA size begins to get enlarged but not too much. And if you take left ventricular and diastolic pressure, it begins to go up. And then the third or the second, it is called pseudonormal. If you have a look at that pattern, if you are just casual, it looks like you're normal, but actually it's not. That's why it is called pseudonormal, because you can see the E, although is tall, but the deceleration time is very short. And your left atrium at this stage is considerably enlarged, and patient is severely symptomatic. Now, I mentioned that you can use echo to predict prognosis and treatment. Now, at this stage, if you use beta blockers in optimal dosage and a good combination of diuretics, which means loop diuretics and mineralocorticoids, believe me, the patient improves within 24 to 48 hours, and 3 to 4 days later, the pattern changes into that one. Another bedside procedure is that you ask this patient to perform Valsalva's maneuver, and after that, if your left ventricle is still compliant, this pseudonormal goes back into that stage 1. And here, the left ventricular and diastolic pressure is really very high. The last one, it is called the restrictive pattern, and you can see the LA size is sometimes so big that it runs out of your screen. And patients severely symptomatic and very high left ventricular and diastolic pressure, and you can see the corresponding pulmonary vein. Now, if you see this pattern, in the first place, a patient, this pattern will not be able to perform Valsalvas. Agar thoda sa kar bhi le, the pattern remains the same. It tells you about very poor prognosis, because your heart is stiff like this, and you can see ye to maine haath se banai hai khud. The moment your ascending limb goes up, immediately comes down. Because left ventricle cannot expand to receive the incoming blood, and very high left ventricular and diastolic pressure. So this is my paper in that. Now, the other day somebody was talking about this B. I always tell people working in periphery that if you don't have the expertise or the facility for pulse Doppler, this M-mode tracing of mitral valve is an excellent tool to predict your left ventricular and diastolic pressure. You can, oh, wo kahan gaya? Ye pointer tha ya? This one. There's no pointer. ये आपको नजर आ रहा होगा. ये M mode नीचे एक bump है. It is called B bump. So this indicates a very high left ventricular and diastolic pressure. So people who don't have pulse mode Doppler or they don't have the expertise is an excellent tool. This is just about tissue Doppler imaging, because your diastolic criteria was very useful. But the only problem was that it was affected by the loading conditions of the heart. And I remember when I was at Mayo, an 18-year-old boy came, and luckily Professor Liv Hatley was visiting Mayo. And they said, oh, this boy has grade 1 diastolic dysfunction. She's a lady. She said, doctor, why don't you take detailed history? And they did that, and the man had severe bout of gastroenteritis that had put him into hypovolemia. They corrected it, and it went back to normal. So in order to take care of these problems, they came up with TDI. And again, with TDI, it was affected by the chest movement. So then the latest was strain and strain rate imaging. We're now coming to the therapeutic approaches. Previously, reduction of salt and treatment of underlying cause, treating and hypertension. Now you have heard latest, treatment, and yeah, this is CRT. Oh, I still have 1 minute. So, yeah, this is. Now you see we have a number of medications available. Diuretics, beta blockers. Beta blockers have to be given in optimal dosage. Where is the paradigm? Because previously beta blockers are contraindicated. Now it's an important and integral component of heart failure. And then, as Dr. Shahbaz said, that you have to have a multidisciplinary approach. a neurologist, a pulmonologist, nephrologist, general physician, and involvement of a trained nurse is important, and family members should also be educated to take care of this, and this approach improves survival after hospital discharge. Thank you, and Major Jokio, I am 10 seconds before time.